Hi class. In this lecture, we will review drug therapy for constipation. The objectives are listed on the slide and they're also listed in your Blackboard module. Here you will find some important vocabulary terms. Please be sure to look these up in your textbook.
In terms of the underlying causes of constipation, they fall into a number of categories. There could be metabolic issues that lead to constipation, such as diabetes or hypothyroidism. So these are physiologic conditions that affect metabolism, and they could lead to constipation. There could be physiologic issues, such as pelvic floor or anal sphincter dysfunction or slow intestinal transit. Drugs can also lead to constipation. In fact, drugs are actually a pretty common cause of constipation in patients. Drugs such as opioids or antacids, anticholinergic drugs, which we talked about recently. Iron is probably one of the most well-known drugs that causes constipation, and even laxatives. So we use laxatives to treat constipation. However, when laxatives are abused, they can ultimately lead to constipation, which is unfortunate. And then probably one of the most common and modifiable reasons patients become constipated is because their diet is poor. Diets that are low in fiber and low in fluid can lead to constipation. So before we talk about the drugs we use for constipation, I want to just briefly mention some non-pharmacologic therapies that can be used. So obviously, poor diets that are low in fiber can lead to constipation. So any patient who is reporting constipation should think about whether or not their diet has a sufficient fiber content. Generally, anywhere from 20 to 60 grams of fiber per day is sufficient to help resolve constipation. If patients increase their intake of beans, whole grains such as bran, fresh fruits and vegetables, this is usually adequate for increasing the amount of fiber in their diet. Increasing fluid intake specifically for patients who are dehydrated. This can also be helpful. And then even exercise, so regular exercise can help reduce the risk for constipation. So let's talk about the medications. So there are 4 classes of medications that are available, and within each of these classes there are multiple drugs on the market. These drugs, for the most part, are available over the counter. If you look in your textbook on page 965, there's an extensive list. We're just going to focus on one prototype for each of these particular classes, like we do for everything else. And because for the most part, if you know the prototype, the properties of the prototype, that information can be generalized to other medications in that class. But basically, what you see here, you can take a look at this diagram, and in the diagram, it just kind of shows you how these different drugs are working to relieve the symptoms of constipation. So your bulk forming laxatives, these are increasing the bulk of the stool, and that's helping the stool to be passed through the intestinal lumen a little bit easier. And then you have surfactants. And so in the diagram, these drugs are basically softeners. They lubricate the stool, and then that helps with transit through the GI tract. You have stimulant laxatives. So the stimulant will increase peristalsis. So the actual GI tract itself will have an increase in peristalsis, and that will help push the stool through the GI tract. And then finally, the osmotic laxatives. So what these do is they bring in fluid into the GI tract, and that's going to increase the fluid content of the stool, and that's going to help the stool to pass a little bit easier. So let's start by talking about bulk forming laxatives, and I do want to mention just kind of a general caution with laxatives in general, and so this would apply kind of broadly to the different categories of laxatives. Certain disorders of the bowels, like a surgical abdomen or bowel obstruction, laxatives need to be avoided because they can lead to very serious adverse effects. Pregnancy and lactation. Now, unfortunately, pregnant patients do become constipated with some regularity. but we are cautious when using laxatives in pregnant patients, specifically like stimulant laxatives or osmotic laxatives, because these drugs can actually influence uterine contractions, and that can be a problem depending on at what point the patient is in their gestation. And then finally, we generally try not to use laxatives for long-term use. Unless the patient has some kind of underlying issue where if they're not on a laxative, they're going to be constipated. Like for example, patients that are on opioids. But generally speaking, we try to address the underlying causes, and we try to avoid using these medications long term. All right, so let's talk in detail about the bulk forming laxatives. And I have a picture on your slide of some of the different bulk laxatives like Metamucil, Fibercon, some of those that you might see. Our prototype is going to be Metamucil. Metamucil is a psyllium preparation. It's basically derived from cellulose, which comes from grains and other plants. And basically, it's kind of like similar to dietary fiber. These drugs are non-digestible and non-absorbable. And basically, what happens is bacteria in the colon and the intestines will feed of this off of the stool that's increased in size because of the binding with these celluloses that are part of the psyllium preparations, and that will actually help the fecal mass to grow. This stretches the GI wall, improves peristalsis. These drugs usually work within 1 to 3 days. Obviously, they're used for constipation, so you can see I have that bolded on the slide in terms of therapeutic uses. But irritable bowel syndrome, constipation can be associated with irritable bowel syndrome, so these are sometimes used for that condition. And interestingly, they're also used for diarrhea relief. So moderate diarrhea, where increase in the bulk of the stool can actually be helpful in diarrhea as well. It seems counterintuitive, but for mild diarrhea, these can also be helpful. Some of the adverse effects, flatulence is probably one of the worst adverse effects associated with these, and that's related to, like I mentioned, bacteria are feeding off of that increased stool size and they're producing gas, so that can be a side effect, and also abdominal cramping. These drugs aren't absorbed though, they stay within the GI tract. So in terms of nursing educations, you want to educate your patient. Always educate patients to take these medications with a full glass of water or juice, and that's because the psyllium itself can get lodged in the esophagus, and so you want to prevent that from occurring. Now, luckily nowadays, these medications are available in a variety of different dosage forms. Sometimes they're like a wafer, like a cracker. Sometimes it's a powder that you dissolve in 8 ounces of water. Back in the old days, these Metamucil had kind of a gritty or like an unpleasant taste to it, but nowadays the newer dosage forms, the patient doesn't even know they're taking it. It completely dissolves. It's it's tasteless. It's odorless. So definitely the technology around production of these drugs has improved. But definitely educate patients to always take it with a full glass of water or juice. All right, let's move on to the surfactants. I have a picture of our prototype. Since a lot of these drugs are over the counter, I will provide you guys with pictures of what the products look like. So we're going to talk about the surfactants. So the prototype is docusate sodium or cholase. These drugs increase the wetting action of the stool, leading to softening. Basically, they kind of have like a detergent action, so it allows the stool to move through the colon a little bit easier. These drugs will work within 1 to 3 days, kind of like the bulk forming laxatives. Obviously, they're used for constipation, and like the bulk forming laxatives, you want to educate patients to take these with a full glass of water. And that's really just to improve the wetting action. All right, moving on to the stimulant laxatives. I have a couple of the over-the-counter products here, Dulcolax or Senokot. So the prototype that we're gonna focus on is Bisacodyl or Dulcolax. These drugs increase intestinal smooth muscle motility, so they increase peristalsis. And because peristalsis is increased, that helps any contents within the intestinal lumen to move more quickly through the intestines. So these work pretty quickly. They can produce a semi-fluid stool in 6 to 12 hours. One of the most common uses for the stimulant laxatives is opioid-induced constipation. Patients that are on opioids, the opioids will bind to receptors in the GI tract and actually slow down peristalsis. And so the stimulants have an opposite effect, so they're very good for opioid-induced constipation. They can also be used for slow intestinal transit constipation and just constipation in general. The main adverse effect that we worry about is cramping, and that is owing to an increase in peristalsis. These drugs are available both orally and rectally. The rectal suppository works pretty quickly relative to the oral dosage form. If the medication is taken by the oral route, these have an enteric coating on them, so they shouldn't be crushed or chewed by the patient. If they are taken along with antacids or milk, they need to be separated by at least an hour because antacids and milk can bind these laxatives and then render them ineffective. And then usually we counsel patients to take these at bedtime because what will happen is they take it at bedtime and then by the morning the drug will be effective and they'll have a bowel movement. One thing I want to mention with the stimulant laxatives is that these are the most widely abused laxatives that are on the market. And they can perpetuate their own use. And what I mean by that is they work pretty quickly and they work pretty effectively. And so they can purge bowel, they can be responsible for purging bowel contents even after just a couple doses. And then it takes several days for the bowel to kind of refill. But the patient may interpret that as that they're constipated again, and then they take more stimulant laxative. And so over time, the defecatory reflex can be diminished in patients that are abusing these medications, and the patients become kind of dependent on them, so to speak, to have bowel movements. So this is actually a pretty widespread issue associated with the stimulant laxatives. So we try to prescribe these for the shortest amount of time possible. We definitely encourage patients to eat more fiber, exercise, engage in some of those non-pharmacologic strategies to decrease constipation as well. All right, and finally the osmotic laxatives. And so I have Phillips Milk of Magnesia here on the slide. That's going to be our prototype. Milk of magnesia is basically magnesium hydroxide. This drug is a poorly absorbed salt. There are many laxative salts that are on the market that are considered osmotic laxatives. Magnesium hydroxide is the one we'll use as our prototype, but these salts increase water content in the intestines. When these are used at low doses, they produce a semi-fluid stool in 6 to 12 hours, and sometimes even quicker. When they're used in high doses, they cause rapid evacuation of the bowel, and this can occur as quickly as 2 hours after these medications are ingested. So in terms of therapeutic use, obviously constipation, especially if the low dose preparations are being used. The high dose preparations would not be appropriate for kind of your general run-of-the-mill constipation. Those are really reserved for situations where you need to rapidly clean out the bowel. For example, if a patient's having a procedure, these medications may be prescribed the evening before or even just before the procedure, a couple hours before the procedure, although that's not ideal, to clean out the bowel if they're having some type of surgery on the bowel or maybe some type of procedure where they need to evaluate the bowel and they need the bowel to be cleaned out. Or in cases of poisoning. So if a patient is poisoned, maybe they've experienced a massive overdose of a drug and you want to get that drug out of the GI tract, that's another potential use for these high dose osmotic laxatives. I think for our purposes, where we're going to see these used most is for bowel cleanouts for procedures. In terms of adverse effects, these drugs can cause flatulence, abdominal cramping, bloating. They can even cause dehydration, which I think makes sense. If you think about the way these work, they're causing water to be pulled into the intestines and then to be eliminated from the body, and so that can lead to dehydration, especially if these drugs are used inappropriately or without the appropriate monitoring in place. Some contraindications if patients with renal dysfunction, specifically if the osmotic laxative it has either magnesium or sodium or phosphate, those can be detrimental in patients with severe renal dysfunction. Heart failure patients, hypertension, edema, again, because of their impact on fluid status. One osmotic laxative, it's not our prototype, but I just want to mention it. We're not going to test you on this, but I do want to mention it, is polyethylene glycol, or Miralax. Miralax is an osmotic laxative. It can be used in either a low dose or a high dose, and again, the results will be different based on how it's dosed. But I want to mention it because it's becoming a pretty commonly used laxative, especially for patients that have chronic problems, maybe patients that have anatomical issues or physiologic issues. It works pretty well, and so it's one of the ones that we're starting to see prescribed more frequently. For now, magnesium hydroxide is our prototype. That's the prototype that was listed in the NCLEX board review materials, so that's the one we're going to use for class.
So let's talk briefly about the bowel cleansing products. This is a table from your textbook. First and foremost, you do not need to memorize this. The only reason that I'm including it is to just show you what these products look like in terms of how they're administered, the volumes that the patient needs to take, and just to kind of point out a couple of important concepts that you might need to know in practice. But again, we're not going to test you on this information on our exam. So as you can see, there are essentially three groups of products. We have the sodium phosphate tablets. So this is 20 tablets that the patient will have to take along with clear liquid. So a couple liters of clear liquid, you can see all the way over to the right. And then 20 tablets the next day, again, along with clear liquid. There's also the polyethylene glycol products that include electrolytes. So this is high dose osmotic laxative, but it is also including electrolytes so that the patient doesn't have profound electrolyte disturbances. Because you can imagine clearing out the GI tract in a profound way, that could lead to electrolyte disturbances. So these products, it's like a big plastic jug. Many of you probably have seen it in the inpatient setting. Go Lightly is probably the brand that is most commonly used. But basically, the patient takes 240 mLs of the product every 10 minutes until a total of 4 liters is ingested, or until rectal effluent is clear. And there are a couple other products there, but they're in the neighborhood of 1 liter to 4 liters of 2 liters to 4 liters total, what the patient's going to take to help that product work appropriately. The final product is a combination product. So this product is sodium picosulfate along with magnesium oxide and citric acid. Again, the patient is mixing the product in water, but also taking several liters of clear liquid. So again, not something you have to memorize. I just wanted to kind of give you a feel for how these bowel cleansing products are used. Okay, so thank you for listening. If you have questions about this content, please post them to the discussion board.